Hello, everyone. Welcome to today's specialty testing webinar on small fiber neuropathy, diagnosis and treatment. This is Amy Ennis, Laboratory Technical Resource Coordinator for Mayo Clinic Laboratories. Our presenter today is Dr. Christopher Klein, Professor of Neurology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the Zoom Q&A function. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn the phone over to Dr. Klein.
Hello, everyone, and thank you for joining us. I'm going to be talking about small fiber neuropathy, which largely just is under the rubric of painful neuropathies. And we're going to talk about various causes and our 20-year experience here in Olmsted County. And we are a small county, about 130,000 people. And this is a pictorialized view of our small city in Rochester, Minnesota. I really don't have any relevant disclosures for the talk, but I will be giving some cases where we're going to talk about treatments of which there are really no FDA-approved treatments for autoimmune neuropathies. So our objectives are to understand recent discoveries in the space of small fiber neuropathy, talk about the incidence, prevalence, the comorbid conditions, the longitudinal impairments and disabilities. And we're going to be talking about the proper workup of these conditions. And then we're going to discuss the role of autoantibody testing based on phenotypes. So when I see patients in my peripheral nerve clinic, neuropathy comes in many shapes and forms. And this is just a cartoonized version of a month of so of my patients in the clinic, with the sensory nerves represented here in blue, the motor weaknesses represented in red. The yellow are those patients who often have CNS involvement. So they may have brain and spinal cord involvement as well as neuropathy. And then many patients will also have a part of the nervous system affected called the autonomic nervous system. So that deals with blood pressure, sweating, heart rate, erectile dysfunction, GI, motility. So it's a quite diverse group of patients in terms of what we see, but they largely present with weakness, sensory loss, and/or pain, and autonomic symptoms. So it's a very complicated space in that, there are over 1,500 different causes for neuropathy, and there have been attempts to try and make it simple so we get patients to the right tests. And so we use the temporal course, we use the presence or absence of pain, and we use the localization on the patient's exam to help guide what possible entities may be most likely, and that guides our treatment. And that's kind of illustrated in this slide, which is a summary by one of my colleagues, Dr. Michelle Maurerman, who tried to make an approach that seems reasonable. So just to let everyone know, neuropathy is incredibly common in the general population. So we did a population-based study in this county that I mentioned to find that about 2% of the entire population has neuropathy. And this slide illustrates that neuropathy occurrence greatly increases as we become older. So by the time we reach Medicare age, about 6% of us will have neuropathy. And it's fairly prevalent between both men and women without big differences. And so when we think about the architecture of neuropathy, there are largely two categories: large fiber neuropathies, and those are people who have weakness and gross sensory loss. And then there's small fiber neuropathies, and these patients largely have a lot of pain. They may or may not have weakness. And so the size of the nerve determines what portions are affected more. And so this is a highly cartoonized form to give you an idea of what the nerve architecture looks like. So the nerve fibers proper within the indenarium here are surrounded by many supporting networks that include lymphatics, vascular structures, circulating mast cells. But then if you look at the actual nerve fibers shown in the below image, they are broken down based on size. So these larger myelinated fibers are involved in ability to feel, gross sensation, and they're also involved in power. Then you have an intermediate size fibers, which are these here that are sort of 5 microns, and those are uniquely specialized for cold sensation. And the group of fibers we're going to be talking about today are these guys right here that are tiny. They're less than 2 microns in diameter. And in contrast to the other fibers, they don't have myelin surrounding them. That's why they don't stain dark blue here. And those are the fibers that we're going to be focusing on today, with or without these other involvements. So this is the sort of summary clinical features of small fiber neuropathy. So most patients present with a length-dependent process. So that starts in their feet. By the time it gets up to their ankles, they may have some hand involvements. Pain is the major manifestation of these patients, but they may have other systemic features like constipation or diarrhea or lightheadedness, or if they're males, erectile dysfunction or dry eyes. And pain is really the major problem that they suffer. So these fibers are particularly hard to study and require specialized testing beyond just routine nerve conductions, which are normal in these patients. So here at the Mayo, we have an arsenal of different approaches that we can utilize to localize the patient's problem to the small fibers. So this is called a tilt table test that is part of our autonomic reflex screen. So the small fibers innervate the heart, and they're important in heart rate regulation. Small fibers are also important in sweating. So patients who have significant small fiber neuropathy will lose their ability to sweat. And the normal heart rate variability that we experience on Valsalving will be abnormal. And patients will often drop their blood pressures on tilting upwards after having been laid down. And then there are other tests that we can use. There's a nerve biopsy approach in earlier era where we would take a portion out of the ankle and look at it under the microscope through the advent of electron microscopy. So this is an example of a blown up image from what I showed you on the last slide of a person who has a significant small fiber neuropathy, because all the nerve fibers that are usually here have been replaced with collagen. So we call these collagen pockets. But this is a very labor intensive and intrusive approach for patients, because to take out a whole sural nerve is no trivial task. And many, about a third, will be left with pain at the biopsy site. So we have less aggressive interventions. We can actually check patients' ability to sweat by using a powder called Azurin Red, and have the patient go into a heat box, and we look at the pattern of sweating. So these are different patients with small fiber neuropathy that have lost their ability to sweat, and the yellow are those areas where they're not able to produce sweat production. So the last one here is the most typical finding that we see in patients with small fiber neuropathy. So we have other approaches. We can use temperature discs that look at cold sensation. We can use nylon fibers to measure the severity of the fiber losses. We can use this test, which looks at heat pain sensation. So small fibers are essential in our ability to feel pain and heat. And so patients can have a shift to increase thresholds, so it takes more heat to feel the same amount of pain. And all these tests combined can help us understand the localization in the small fibers. But most patients, before we go to a small fiber diagnosis, have had a nerve conduction study. And the nerve conductions, we stimulate the nerve with electricity and measure the response. So in pure small fiber neuropathies, this test is normal, because this test does not measure the small unmyelinated fibers. In the nerve biopsy, we can also look at teasing out the individual fibers. But again, this does not really look at the small fibers. So the current approach that most places that especially don't have access to the complex testing I mentioned is an epidermal skin punch biopsy. So a 3 millimeter punch is performed in the areas where patients have either pain or small fiber sensory loss. And then the tissue is exposed to an autoantibody called PGP 9.5 that stains selectively the unmyelinated fibers. As you can see here, the arrows are demonstrating the small fibers as they project from the dermis up into the epidermis. And we can count those fibers and obtain an accurate sense of whether the patient is losing small fibers. So we don't have to do a whole sural nerve biopsy and put patients through electron microscopy in the current era. Okay, so, there's been a lot of discussion about what constitutes a small fiber neuropathy. So many patients who have generalized neuropathy, who have pain, will have small fiber neuropathies. But to be considered as an isolated small fiber neuropathy, you need to achieve the following results. So you have to have a clinical exam that shows abnormalities in pinprick, which is pain, or heat pain involvements. And then if you have quantitative sensory testing, then those abnormalities are also realized as abnormalities in heat pain or cold sensation, or both. And then increasingly, the standardized diagnosis includes pathologic evidence of reduced fiber densities. And then again, to exclude large fiber involvements, you should have either a normal nerve conduction study, but on bedside examination, normal vibratory sense and normal proprioception, which are subserved by the large fibers. So this is a standard consensus diagnostic criteria established by a number of different organizations to make the diagnosis. So I want to emphasize that these patients are frequently seen in doctors' offices because the pain is so overwhelming. And in fact, we many times will see patients with significant weakness appear very late in the disease because they're not really that bothered unless they're athletes or laborers or people that may be early aware of their weaknesses. But these patients, even at the earliest signs, present to their doctor because the pain is distracting and is intrusive and makes them worry that something serious is going on. So we were very curious about this entity and trying to understand what is the prognosis, how common it is, what are the things that cause it. And so we looked in our Olmsted County and adjoining counties at a 20-year experience with this disorder. And this was just recently published at the end of 2021 in our main journal, Neurology. And it was really received with a lot of interest. It got a number of different kudos. It was featured as an editorial in the journal, and then a number of the news organizations picked it up because it sort of dealt with not only the fact that this is fairly common, but also that many patients really had not had a diagnosis previously. So I'd like to share with you some of the results from the study. So pain was the most common thing that brought patients to the doctor, which is present in 95% of these patients. But in general surveys of their overall neurologic health, they had a number of other symptoms that, on interrogation were present. So a little more than half, about 60% of the men had erectile dysfunction. Constipation was common. Lightheadedness and palpitations of the heart were common. Many patients had urinary symptoms or diarrhea, dry eyes and dry mouth, sweating abnormalities, problems with constipation and gastroparesis, either too fast or too slow. And then others had just sort of multiple autonomic symptoms. But by and large, these findings of autonomic dysfunction were not the major reason the patients were in the doctor's office. It was really about the pain. So these are other demographic data that we learned. So comparing to age-matched sex controls in our county, opioids and analgesics were very commonly used. About 72% of them were on some kind of pain medicine, frequently with narcotics. The process was more common in women, and there was more frequent obesity compared to the matched age and sex controls, with frequent insomnia. And interestingly, many patients had hypertriglyceridemia, significantly different than age-matched controls who did not have this problem. And of course, diabetes was very common. In the study period, 51% would develop diabetes, although interestingly, only about 15% of the patients initial presentation had diabetes. So many of them were labeled as idiopathic, who then shortly after developed diabetes. Okay, so what happened to these patients? What was their outcomes? Well, there's measures of neurologic impairments. The most popular, of course, is the Rankin scale. And it's a 0 to 6 scale where 6 is death and 5 is basically requiring total care. So a 1 is mild interference with daily activities, but not at any extent that keeps them from participating in vocational or household chores. And you can see that the number is quite low in these patients, with pain being the major issue. Compared to controls, they were a little worse. The average in controls, of course, is normal. So what about their comorbidities? What other problems do they have? Well, they tend to be unwell. They tend to have other multiple comorbidities in the Charleston Index. So this looks at things like diabetes, rheumatoid arthritis, heart failure, a number of things that are very commonly causing poor quality of life. And so you can see that it's about twice that of healthy, or not healthy, but matched controls in the county. So then we looked at how severe was their autonomic involvement. And this is the CAS score. And so higher scores are indicative of more severe problem. And for the most part, patients were quite mild at a lower value here. And then we looked at their neuropathy impairment score, which was very low. This is a score that goes all the way to 180 some points. So for the most part, these patients over time did not evolve into significant deficits. But what was important was that either the neuropathy impairment score or the autonomic impairment scores, if they moved at any significant rate, they were much more likely to have not idiopathic causes of small fiber neuropathy, but causal forms like amyloidosis, both inherited and acquired, Fabry's disease, or poorly controlled diabetes. And then we had one patient who had Lewy body disease, which can also associate with small fiber neuropathy and dysautonomia. Okay, so what about their life expectancy? So if we looked at the entire cohort, they commonly had things above and beyond what we saw in generalized neuropathy patients, that the generalized neuropathy patients being those that had both large and small fiber involvements. And so what was quite interesting among the small fiber patients is they had much higher rates of heart attacks and rheumatologic disease compared to their matched neuropathy, generalized neuropathy cohort. So how does that translate into meaningful outcomes? Well, it turns out from the time of the diagnosis of small fiber neuropathy, patients had a much higher occurrence of death. They had mortality from heart attacks, much more so than their matched age controls. And this was actually slightly worse in patients who had causal forms, with diabetes being the most common. But among the idiopathic forms, this also was observed. So if you make a diagnosis of small fiber neuropathy, you have to be very concerned that this patient has an increased risk of cardiovascular disease beyond just what is largely a minimally symptomatic but distracting condition. And so with this longitudinal study, we were able to look at the occurrence over time to realize that since 1998, when all the tests that I mentioned to you have been available for testing, that there has been a slow increased rate of the disorder. So we don't think this is because of greater awareness of the disorder. We think that this probably relates to other factors. Most commonly, we see that this same slope mimics the rates of obesity and hypertriglyceridemia in our cohort. So obesity may be a driver for this increased occurrence. So even though the number is small per 100,000, if you look in a county of ours over this amount of time, this translates into a significant number of persons that are affected. So in Olmsted County alone, there are probably 40 to 50 persons who carry the diagnosis and are receiving care for it. Okay, so what about the causes? So 70% were without a known cause. And among those that a cause was found, this is sort of the breakdown of which diabetes was most common, followed by multifactorial or inflammatory immune conditions, including rheumatologic disorders, and or autoimmune neuropathy causes. Sjogren's patients were also noted to have this, and among patients who improved with immunotherapy, these patients were noted to be some of the best improvers if you looked at their neuropathy impairment score or their pain scales, and then some of these other entities which are rarer. So as I mentioned earlier, diabetes by the end of the study was common, although not always present at the beginning. And then interestingly, about a third of the patients would move on throughout the study period to develop large fiber involvements. And then another important factor is that 18% of these patients had foot ulcers, of which the majority had diabetes mellitus. And of course, an ulcer is a very serious problem of patients who have small fiber involvements because they often cannot feel heat pain when it gets to a more severe small fiber neuropathy. They may have pain, but they may also paradoxically not be able to feel pain. Okay, these are some exception patients. So we did have some patients who did not present with a typical link-dependent pattern. And interestingly, most of them presented with a rapid onset. They had truncal involvements, as shown here in this patient who had diabetes and had rapid correction of blood sugar. And with that rapid correction, meaning a hemoglobin A1C improvement of 3 points or more over a 2-month period, that sometimes induced attacks of horrific pain in these areas where you can see loss of sweat production. And we also saw this same pattern in patients who had underlying malignancies or inflammatory immune causes, including post-viral syndromes. So a patient gets influenza and in the recovery stage develops this kind of painful asymmetric process. So I'm going to change gears a little bit and talk about what has been a huge advancement in the diagnosis of this condition, which is the skin punch biopsies, because they can readily be done in any doctor's office. And the test, even though the antibodies were first described at Mayo Clinic back in the 70s, really did not take off because of the issue of significant overlap in the fiber densities based on ages. And so what was undertaken by my colleague, Dr. Peter Dick, was he gathered together a very large cohort of healthy persons and looked at different quantiles of age. And then he looked at a diabetic cohort. And what you can see is there's quite a bit of scatter at the younger ages for fiber densities that in some ways becomes less obvious at later age. But among the diabetics, they have a reduced density. And so one of the big things that came out of this work was that to increase the confidence interval for any one patient's fiber counts by counting more fibers, you can improve the accuracy, which is shown here in this slide. So if you look at the distal leg or the thigh, and you look at confidence interval counting only one section versus 9, you can increase the confidence interval so that you have 95% accuracy in your diagnosis of a small fiber neuropathy. So that was a huge improvement in the fiber counts done that we do routinely in the lab. So this generated a send-out test that Mayo performs with a kit delivered to the doctor's office that has all the various fixatives and all the tools you would need, and an instructional PowerPoint for those who are interested in doing this procedure. And so I do want to make a plug for the lab because I think they do an amazing job. And when I see patients over in the clinic and I get an outside punch, I often am questioning that because the patient has normal sweat tests and other tests that we've run them through. And so when we repeat the biopsy, here would be an example of our Mayo staining. And this was a patient who was told they had a small fiber neuropathy based on the punch biopsy and was told they had no fibers, but it really was a resolution issue. So you have to be a little bit careful if you're going to do these, that you understand the lab performing the test and their accuracy. And in fact, some labs we cannot find a normal study, and I think it's because there's some technical concerns. And so this just summarizes the 221 data from our lab, where we only had about 17% of these cases that were biopsied to be abnormal, and 11% were kind of on the borderline range. So what are the other things that can mimic small fiber neuropathy that doctors need to be aware of? So this is again from our 20-year cohort, So there are 89 patients who were initially suspected of having small fiber neuropathy, who in the end either had a generalized large fiber neuropathy in addition, or they had other diagnoses like a myofascial pain disorder, like you can get with fasciitis or tendonitis. Very interestingly is that a very significant proportion had gout. And these patients, I can kind of sniff them out in my clinics because if I'm going down to the room to see the patient, many times they will be in a wheelchair. And that's because the pressure on their feet makes their pain so much worse, which is generally not seen in small fiber neuropathies. It's much more likely that's a rheumatologic process that gives them joint or tissue tenderness on palpation. Some patients had fibromyalgia, and others were sort of rare diagnoses. But anyway, this is a tool that we use here at Mayo. It's called dual CT for patients where we suspect gout may be the cause. And it uniquely shows all the gouty deposition in a patient who really has never had a frank red swollen toe, which is a typical presentation for gout. So they actually have a psoriatic involvement of the joint that does give them significant palpation tenderness, and to the point, like I mentioned, they may not even be able to walk on the feet. Okay, so I've kind of done the overview of the condition. I'd like to go through some cases to drive home some diagnostic approaches. And I'll share with you that many small fiber neuropathies that I'm going to be talking about, these cases are actually extremely rare. They're probably not as rare as this flower. If any of you are interested in flowers, this is a flower that was discussed by Buddha that blooms only 1 in 3,000 years. So this is a very rare picture of that event. So our small fiber neuropathies I'm going to talk about are not that rare, and you need to be aware of them because they can commonly be missed. So I'm just going to start with the case of a young boy that I saw who had a terrible burning in his feet. That sounds very classic for small fiber neuropathy. And it was induced and made worse by playing sports. So when he was a little guy, he'd play t-ball, and every time he'd run around the bases, he would get these attacks. It was made worse in hot weather, and now it was constant. It didn't take the weather alone. It was just there all the time. So in his review of systems and his past medical history, the only other problems that were in his chart was that he had some mild hearing loss as a little boy. Not enough that he needed hearing aids, but enough that the school counselors were aware of it. And as he got older, he had been labeled with irritable bowel syndrome. He was said to have very dry skin. He had bloodshot eyes, and he had a belly button that was always felt to be infected by a fungal infection or candidiasis. And so his family history was this. Here's our patient. His mother, unfortunately, had died at a young age in a motor vehicle accident, so there wasn't any real information there. But her sister and father had issues related, they thought, from diabetes, and the aunt had, I think, heart failure as well. But she had pain in her feet that was similar, but had been attributed to diabetes. Okay, so this is our young man's examination. And as is typical for most small fiber neuropathy patients, it appears to be a fairly normal exam. So in the Mayo scale, zeros are normal. So joint sense, temperature sensation was fairly normal. His reflexes were all preserved. But when he was sent to the heat pain test that I showed you earlier, looking for a disturbance of small unmyelinated fibers, he was found to be hyperalgesic. So he felt pain at the first percentile. So a small stimulation led to a big problem. And so a point being that some small fiber neuropathies initially begin with pain, but without frank sensory loss. In fact, hyperalgesia. So this was his sweat test. As you can see, he has difficulties in sweat production kind of all over, including in his belly where he'd been told he had fungal infections. He had hearing loss. And this is a picture of his skin. This is his belly button, and this is actually his thigh. And he had these little raised papules. And in fact, this is not candidiasis. These are angiokeratomas. So he had Fabry's disease. And this was confirmed by enzymatic testing for alpha-galactosidase with a known mutation. And in further review of his laboratory studies, he did have mild kidney involvement, which is typical for this disorder. So at Mayo, if you're seeing a male with this disorder, we start with alpha-galactosidase. But females, although this is an X-linked disorder, can be manifesting. And they can have very similar clinical phenotypes to the boys. They just generally start a little later because they do have one good chromosome making alpha-galactosidase. So in general, we don't order alpha-galactosidase in girls. We order this test, which is called ceramide trihexoside, as it's more sensitive in the urine to find an abnormality of the enzyme. So if that is abnormal, then we confirm with genetic testing. And the reason we don't start with genetic testing is that there are many polymorphisms or pseudogene abnormalities that can lead to false positives. So we start with the biochemical assay first, and then we confirm with genetic testing. But this just sort of summarizes the different problems these patients have. So almost all of them start with pain in their feet as the first manifesting feature, but over time they develop a significant number of problems, most prominently being kidney failure. And they have a shortened life expectancy. So the men, their average life expectancy is in their early 50s, and in the women, it's about a decade later. But it's a big problem of which patients present initially with small fiber neuropathy. So the reason we want to make sure we don't miss these patients is now there are fairly successful therapies to reduce the rate of renal failure. The most recent of which is this oral medication called migalastat, which is a very interesting drug. It's within the class of drugs called chaperone therapy. So it actually binds the catalytic domain of the protein. And paradoxically, that allows for increased enzymatic activity by preventing the enzymatic protein from being degraded. So again, we want to make this diagnosis. We don't want to miss these patients, and certainly we don't want them to get to the point that they're having kidney failure before they're diagnosed. All right, I'm going to move on to the second case. This is a more typical case, I think, that we might see in our clinics of an older man who has burning in his feet, but he also has a spinal stenosis, which results in him not being able to stand for a long period of time because his legs get pained and he has to sit down. He's had a history of carpal tunnel syndrome, the stenosis I mentioned, and he has diabetes, but it's very well controlled. He has no retinopathy, no kidney involvement, and his A1Cs are excellent. But unfortunately, despite that, he's had heart failure. This is his family history. There really is nobody affected with similar symptoms. This is his sweat test, which shows he had reduction of sweat in his feet, and he underwent a skin punch biopsy. So although you see he has lots of fibers, there's something very important that was also found on his biopsy, which was amyloid. So you can see the chondrophilia here, that apple green birefringes on polarized light. So the cardiologists are seeing him, I'm seeing him, and the blind men get together and talk about this element, as it were, to realize that he has heart failure that is caused by an accumulation of a protein called TTR, transthyretin. So transthyretin is a common cause of inherited amyloidosis, but it turns out that among patients who have heart failure without vascular cause, 10% have it as a result of an accumulation of a non-mutated TTR protein, or also referred to as wild-type transthyretin amyloid. And so there has now been FDA-approved treatment for these conditions. This is a drug called tafamidis, and it's interesting in that what it does is it promotes the homotetramer form of this protein, which is less likely to form amyloid. So it's actually a stabilizing drug of the tetramer form. So that's FDA approved for patients who do not have the mutation, but have wild-type cardiomyopathy. But there's been a huge progress in the treatment of the inherited form of this disorder, TTR amyloidosis. So these are two very large, famous trials published in the New England Journal back in 2018, whereby a small molecule was given to reduce the amount of TTR circulating in the bloodstream. And it not only reduces the mutant form, but also the wild type. And so what this shows is the improvement in the patient's neuropathy with introduction of this drug. So both these drugs are now FDA approved, but they were inconvenient in that there were either subcutaneous injections or IV infusions at a fairly frequent occurrence. So there are now several new clinical trials that are utilizing a carrier molecule to increase the efficiency of TTR and reduce the toxicity that can sometimes occur, such as thrombocytopenia, which is a common complication for one of those two drugs. And also that's happening, there's a clinical trial going on to look at whether these same treatments can be used in the wild type TTR patients. Okay, so the last case here is of a 72-year-old man who was a professor at a noted university, had never been sick a day in his life, was on no medications, was an avid runner and full-time professor at the university, who all of a sudden one day, literally over a day to day and a half, he developed whole body pain. The pain was excruciating. He labeled it 10 out of 10. He was in the emergency room multiple times without an explanation. And his wife also noted that he became uncharacteristically very anxious. He was a very cool dude. He never worried about anything. And now he was worried about everything. He would watch the news incessantly. He would worry about all events, big and small. So eventually I was able to see him. He had nerve conductions that were normal. He actually went through a whole sural nerve biopsy shown here that was entirely normal. I couldn't find any abnormalities. And so I ordered a bunch of laboratory tests, including a test for autoimmune neuropathy, which he left, and the test was still pending. And at this point, he'd been gravitated on a huge dose of narcotics. He was on 30 milligrams of methadone 3 times a day, but still in terrible pain. And so what came back after he left was that he had an autoantibody. Initially, we found that he had an antibody to the potassium channel, but that is just part of the complex of which we know is a specific antibody, LGI1. So this protein is very important in regulating the potassium channel in both the central and the peripheral nervous system. And potassium channels act as the brakes for pain. So once you depolarize a channel, the potassium channel rushes in and reestablishes the membrane conductivity with the sodium channels. So these patients essentially have a defect in repolarization. So they have lots of pain, but they can also have, because it's expressed in the brain, cognitive involvement. And many patients develop frank encephalopathy to the point where they're confused or stuporous or even comatose. He did not have that phenomenon. So what we did is we started him with an immune therapy. So we gave him a gram of IV methylprednisolone. This is a very kind of standard large dose. And I got a call through the operator that he was in a coma after having received just 1 dose of IV methylprednisolone. Well, it turns out he really wasn't in a coma, but he was heavily sedated because all the narcotics that he required previously were no longer needed. So in a quick wean of his narcotics, he woke up and described his pain as almost completely resolved. So with that initial 2-week experience, we switched him over to an oral medication, methotrexate, to help fight this autoantibody. And he was able to completely discontinue his methadone. And he's largely on just the methotrexate now and a very small dose intermittently of steroids. So this case has another number of illustrative points, one of which is that in the early portions of the disorder of a small fiber neuropathy, an autoimmune small fiber neuropathy, they may not have significant histopathologic or physiologic abnormalities measured on our routine tests. But we now know from following many of these patients longitudinally that had delays in diagnosis that eventually they all will develop loss of small fiber density. So fortunately for him, that wasn't the case. So this is similar to what I mentioned with Fabry. So if you start off initially with pain, it takes a while before you start losing fibers in those conditions. But this is just a cartoon highlighting all the different particular places of which an autoimmune pain syndrome can be generated, where the small fibers are the common final pathway, either in the brain or in the peripheral nervous system, to lead to this problem, and some of the antibodies that have been found and responsible. But many of these autoimmune or inflammatory immune causes of pain include cytokines. Cytokines are very important regulators of cell membrane potentials. So in the sign of any injury, we increase our cytokines, which allows us to lower the threshold at which a pain fiber will fire. And if you want to learn more about this, this is a very nice review written by one of my prior fellows, Dr. Zhu. So just in general, the patients with LGI1 and Caspr2, many of them had previously been labeled with fibromyalgia, but it was through the advent of the sweat test that was realized that they actually did have fiber counts that reduced and had these antibodies, either LGI1 or Caspr2 in cause. So Caspr2 patients more commonly have peripheral involvements than LGI1, as illustrated by this experience from our cohort here in Rochester of 256 patients. And this is just a shadow plot showing the different involvements of the nervous system, with seizures and central nervous system involvements more common with LGI1 and peripheral involvements more frequently occurring with Caspr2, including cramps and fasciculation. Some patients will come in with horrific fasciculations all over their body and have terrible pain, and that is been sometimes referred to as either Isaac's or armadillo syndrome, because these muscles, not only are they moving, they become rock hard eventually. So what's the appropriate approach for such patients in terms of autoimmune testing? So we've established a very long experience with a larger panel of antibodies to learn that those in red are really the ones that are most helpful in identifying patients who have pain and small fiber involvements. LGI1 and Caspr2 are the most common to have isolated small fiber neuropathies, but all these other antibodies listed here can have a lot of pain because of the small fiber involvements, but they also will have large fiber involvements as well. So we've largely eliminated these other antibodies because what we learn is that they're very nonspecific and can be elevated in a whole host of non-autoimmune conditions, including things like ALS. So by focusing on these antibodies, we greatly increase the specificity of our assay. This is just kind of a summary of the different clinical phenotypes of those antibodies that were under the umbrella. And most patients with those antibodies present with subacute onsets. They tend to be multifocal, affecting the nervous system in the brain, spinal cord, the autonomic or small fibers. They are often asymmetric, as shown in this cartoon, and they frequently will have cancer as the cause of their problem. So they're ones we do not want to miss because they can sometimes be an indication of an early malignancy. And so you can, in the LGI1 and Caspr cohort, have more of these isolated small fiber involvements, whereas the other antibodies will more commonly have motor involvement, shown here in red. So those are important ones not to miss. And so this is just a summary of the antibodies in our current axonal autoimmune antibody evaluation, the types of neuropathy that they have, and or the coexisting central nervous system involvements that they may experience. Sometimes these are the major component and the neuropathy is overshadowed, but often it's the other way around. And then this just summarizes the cancers and their frequencies. And what you can see here is that many of these have very high cancer occurrences. So for most of these antibodies, the occurrence of cancer is over 70%. So they're definitely things we do not want to miss. And so this is kind of a breakdown of our last year's experience in terms of the type of antibody discoveries we're getting. So crimp positivity was the most common antibody, followed by Caspr2, ANA1, and ANA3. So it's important to have a fairly high pretest probability in ordering this test. So again, subacute onset, asymmetry, pain, commonly multi-system neurologic involvement. So they have some kind of encephalopathy. They may have had a seizure. They may have significant dysautonomia, so GI dysmotility. And by doing that, you'll increase the likelihood of a positive result. Okay, so I'm going to just summarize here, and then we can move on to some questions to talk. So the first thing is getting the diagnosis correct. I think I emphasized that frequently pain is caused by non-small fiber neuropathy cause. So we're looking for findings of nociceptive either hyperexcitability or nociceptive hypoanalgesia, so they can't feel the heat, pain, or pin. Looking for cursory autonomic involvements, doing the exam carefully to look for small fiber involvements, and utilizing reliable quantitative testing, which I think right now, for most places, it is the skin punch, but being mindful of the potential false positives that can occur if the test is not performed carefully. So what are the labs that we typically get? Well, because diabetes is so common in these patients, every patient should have a thorough review for early diabetes. So I like to use the hemoglobin A1C because it measures the average blood sugar over a 3-month period. Sometimes I'll do a fasting plus a glucose challenge, and I look for early signs of kidney involvement with microalbumin. In terms of other autoimmune syndromes, as I mentioned, there is a higher occurrence of rheumatologic diseases with small fiber neuropathy. So I'm frequently going to be ordering tests that look at coexisting rheumatologic process, including uric acid, which I have not listed here, for gout. So I often will do monoclonal proteins with a mass spec assay. And the reason I'm doing that is to look to exclude primary amyloidosis. And then among metabolic causes, I, of course, always will order a B12 and a folate because those are quite treatable and not that uncommon in the population, deficiencies of those vitamins. So in rarer patients, based on some clinical pearls, as I tried to highlight by the 3 cases, is I will expand my testing to include the autoimmune axonal evaluation I reviewed, transthyretin sequencing, alpha galactosidase, or in boys, or the GB3 or ceramide test I mentioned. And in some patients, I didn't have any cases of that, and our series will look for mutations in a gene called SCN9A that can cause a condition called erythromelalgia. And these patients are hallmarked by very heat-inducible symptoms with bright red feet when their attacks occur. So among the infectious causes, I might order an HIV. We did have 1 patient in our series that had HIV small fiber neuropathy. We didn't have any Lyme patients, but in the Midwest, it's not uncommon to see Lyme with small fibers and fiber involvements. And then I kind of outlined this already. So what do you do for these patients? Well, because pain is generally their main problem, we make sure that they don't have a disorder that will evolve into something worse, like diabetes. But for most patients, we're utilizing medications in the class of epileptic drugs because they actually stabilize membrane potentials that reduce the painful symptoms. But one of the big things we're doing is giving patients realistic expectation that these pain medicines can help, but there really are none that completely eliminate the pain. But in general, with maximal dosing, we can reduce pain by about 60% with any one of these medications shown here. I favor gabapentin. It's well tolerated. It doesn't have some of the side effects in some of these others. And it's now on a generic variety, so it's really inexpensive. And then, of course, look for and treat the underlying cause. And remember, the underlying cause may not be apparent in your first visit. So follow-up is very important, looking for evolvement of diabetes or other inflammatory immune processes. And as I highlighted, because 17 patients in our cohort had ulcers, that good foot care is important to teach patients and so that they won't develop ulcers that can lead to infections and amputations. And of course, if you see an ulcer, be very suspicious that they have now evolved into diabetes, because 70% of our patients who developed ulcers developed diabetes in the study period. And the other thing that's emphasized, and I think one of the reasons the paper got picked up by all the major news media, is the common occurrence of cardiovascular disease in patients much higher for their age and sex match controls than seen even in our general neuropathy cohort. So there's something about small fiber neuropathy that puts people at risk for heart attacks. And so letting patients know that they need to be more vigilant about their cardiovascular risk factors is very important. And for those patients where no cause is found, we recommend that they continue to check their blood sugars, into the future because of the common conversion into frank diabetes. And so the other thing that neurologists will appreciate is that they really don't need a yearly clinical examination. They need to be following with their internists for the cardiovascular risk factors and other medical issues. But for the most part, unless they develop rapid new symptoms or signs, they don't need to be seen annually in neurology clinics. So this is our goal, to try and push on the analog pain scale patients to a happier life with less pain, to the point that they can carry out all their ADLs, enjoy their vocations, hobbies, and families without distraction.